Today we are joined by some great speakers, Evelyn Graham-Nyaasi, Jim Bohovich, and Jim Mutton. Evelyn is a mental health and housing advocate whose work is shaped by her own experience with housing insecurity and mental health challenges. She is particularly interested in promoting more humane responses to people experiencing mental health crises. Evelyn is a NAMI NYC advocacy ambassador, an executive member of the Peer Justice Initiative, and a member of the Daniels Law Coalition. Jim Bohovich currently works as a peer specialist on an intensive mobile treatment in the Bronx. He has worked in a variety of different programs in public mental health, mobile crisis team, inpatient hospital unit, and intensive outpatient, among others. And then Jim Mutton currently serves as the Associate Executive Director of New York City Program Operations at Concern Housing, a leader in the development and operation of supportive housing on Long Island and New York City for the past 52 years. He previously worked as Director of Residential Services and for Project Renewal, and currently serves on the board of the Health and Housing Consortium. Now I'll pass it over to my colleagues. Thank you.
Thank you.
Thanks, Harmony. Hi, everybody. Happy Thursday. Thank you for joining us on your lunch break. Hopefully you're getting a bite to eat and you can chime in on this discussion. We're delighted to be joining you to tell you a little bit about CCIT-NYC. And we can go to the next slide. So about 10, maybe 15 years ago, I was working at an agency, Project Renewal, in Midtown Manhattan. And I hooked up with our neighbors at Fountain House, the big clubhouse on 47th Street around the corner. And there was a wonderful array of advocates and peers at Fountain House that told me about some work they were doing with local police, particularly rookie cops who were new to the precincts of Midtown North and Midtown South. And they told me that they would go to those briefings for the rookies in the morning, and they would talk to the police about mental health, particularly about mental health crises. And the focus at the time was really just to provide a layer of education and understanding about what recovery was and how we could interact appropriately with the police. And from that, I met a wonderful woman named Carla Rabinowitz from Community Access, who told me about this correct, at the time we were known as Crisis Intervention Today. And she said that we were not only going to local precincts, but we were actually going to the police academy to provide some training to police at all levels, not only rookies, but sergeants and folks out on the beat. And I went to Long Island City, and what a remarkable place the police academy is. It's this massive complex where they have literally staged areas that are supposed to resemble New York City landmarks. So they have a deli, they have a subway car, and all types of landmarks that they use to do staged interventions with people with mental health issues who were in crises. So they were bringing in trained actors to do these sort of mock crises to help the police learn de-escalation skills. Carla told me that she had been invited to participate, to have input on what the curriculum was, and also to do some demonstrations herself. So I hooked up with Carla and a few others, and our goal at the time was really to try and train the police on de-escalation. And we ended up designing a curriculum that would go on to be trained to tens of thousands of New York City police officers. So we can go to the next slide. So that small group has blossomed into a much larger stakeholder community. And the bulk of our community are folks with lived experience. And I'm so delighted to be joined by a couple of my favorite people from the CCIT-NYC campaign, Evelyn and Jim today, who have really become strong advocates in the work that we do. Our goal at this time is to come up with an alternate crisis response system that doesn't involve the police, that involves people with lived experience or peers, as we're often use those terms, who can be at the forefront of responding to a crisis. And we'll go to the next slide. So we did this training at the police academy for a number of years. We worked with Mayor de Blasio, and there were a number of mental health reports that came out. The police underwent 3 days of intensive training on crisis de-escalation skills. We got to know many of the officers. It was the first time that they talked openly about mental health issues themselves. And this, as we've heard about a blue wall of silence often in the police force, that it was seen as a weakness to talk about mental health, certainly if it was impacting an officer or a family member, a loved one. And it opened up the conversation to really have a dialogue with those officers. Many became accredited with crisis intervention skills, de-escalation skills. They were given a special pin for their uniform. Many of them were deployed without uniform. They would have special jackets and they would go out on teams. Sadly, this training didn't see the results we were hoping to see. There were not enough officers deployed to situations at the right times, or there were officers deployed who'd had the training who weren't using the skills that were necessary in those frontline crises. And since that time, in the mid 2000 teens, we have lost over 20 folks in mental health crises. And you can see some of their faces and names on the screen here. Evelyn, did you want to add to that?
I wanted to add that not only were they not deployed, the officers that were trained did not go because they often switched precincts on where the calls came in from. So if you are a person and you regularly know the individual in your neighborhood, a lot of the murders or killings occurred because officers were transported over to the neighborhood and they did not know the person's background. So that's something else that was going on.
So thanks, Evelyn. So, the outcomes were not meeting what we had hoped for with the training, where there was a real hope that we would see a difference, we would see a dramatic decrease in fatalities and serious injuries. That wasn't the case. So we'll go to the next slide. So CCIT began to pivot. We decided that training alone was not sufficient and that we needed to come up with a different type of model that would allow people with lived experience to be first responders, that we understood that many people in crisis on the streets, in their homes, in their own homes, and many of the folks that you saw on the screen prior lost their lives in their own place of residence. That wasn't enough. We needed a system that would approach things differently. So we came up with a proposal that would essentially deploy trained peers with an emergency medical technician, someone who's not directly affiliated with 911 and our cost system, that would be a team that would operate 24 hours a day, 7 days a week, year long. And that those folks would be the first responders. That our hope was that someone with lived experience would be able to make its connection with someone in crisis and perhaps avoid the need for the police entirely. There
So
would
Jim,
also be, Jim, you wanted to add
yeah.
to that?
So I've been lucky enough to work on a mobile crisis team. It was actually out in Lawrence, Kansas. And as a peer specialist, it just makes a tremendous difference when it's a peer specialist. We used to go out as a team of two. One was a therapist, social worker, and the other one was a peer specialist. And, a lot of times I would get to take the lead, and it's so much different when two people like that show up as opposed to one cop car or multiple cop cars with, sirens screaming and lights flashing. And, peer specialists and social workers, we don't carry guns. So the feeling is that just by the police showing up, everything gets escalated, which is certainly the opposite of what you would want to happen during a mental health crisis. And then as peer specialists, our core function is to develop a deeper connection with the people that we work with. And, as time went on, when I was working there, I found that I could do it rather quickly because in my previous roles, I met with people for much longer periods of time. But you find that when people are in crisis, if you can help them to de-escalate, then they're much more open. And a lot of, like, we would talk a lot about there being a large opportunity in crisis because people realize what they just went through. And then the feeling and the desire to change can be really strong. And when there's a peer specialist and a social worker there, as opposed to the police, we can more take advantage of that and help them work through that and provide appropriate resources. And it was a really eye-opening experience for me. And it certainly works better than the police showing up.
Thanks, Jim. And, along with what Jim was saying, we were seeing changes across the country in terms of crisis response systems. There were alternate systems being set up that didn't necessarily involve the police, that were using social workers, that were using other clinicians who would be first responders. We saw a lot of respite centers, crisis stabilization centers. New York City has its own parachute model of crisis respite. These were all opening up around the country as alternatives to typically taking somebody to an emergency room or a jail cell. So we'll go to the next slide.
I just wanted to add that when people are taken to the hospital, they're released back into the streets without any follow-up care or anything or wraparound services. So that's something else that we're advocating for with the CCIT proposal, that that they would receive wraparound services, housing or medical care or whatever they need. And right now, that's something that's not being done.
So Evelyn, would you like to say a little bit about your story and maybe take the next slide?
Sure. Hi, my name is Evelyn. I have been diagnosed with bipolar depression. I've lived with it for 34 years. Before the incident that I'm about to describe to you, I was not hospitalized for 25 years until one day I was sitting on my sofa and there was a knock at the door. And when I opened the door, there were 8 to 9 police officers outside of my door with guns. And one of the officers told me that someone from my home had called 911 and said that I had a knife. I did not have a knife. I was not acting out of character. There was no knives near me or anything. So he told me that I had to go with him. And because I've known that, what happens with people with mental challenges, um, and the police officers, I was very afraid. I just grabbed my medication in my jacket and I went downstairs with the officer. And when I got outside, he actually said to me, "Do I want to get into the police car or the ambulance?" And I had never been to jail or anything like that, so I chose to go into the ambulance. They took me to Bellevue Hospital. They dropped me off there. I was there for, it was a 4-day weekend. My family could not find me for 3 days, so that was a nightmare. They wouldn't give me my medication. Um, there were no doors, or it was just a horrible situation. And when Tuesday came around, they took me upstairs to the ward, and because I didn't know I had rights, I ended up staying there for 7 days. And when I was discharged, there was no wraparound services really. So that's what's going on with that. And if there was a peer, someone with lived experience there with these officers who accused me of having a knife and I didn't, a peer would have been able to advocate for me and also, de-escalate the situation with the police officers, because I was not giving them any problems or anything like that. And because of that, I think that with all the individuals that were being killed, if they had a peer, none of this would have happened. So that's where we are.
And Evelyn, thank you. Would you like to take us through this slide on the screen?
Healthcare responses to mental health crises are universally considered the best care. In New York City right now, we have a public safety thing that's taking care of people in mental health crises. They have Be Heard. What Jim didn't mention is that CCIT had advocated for non-police response under Mayor de Blasio. And instead of him giving them that, he gave them a co-response team. And CCIT didn't want that, so we all went back to the drawing board. And once, we learned that so many people were dying, we decided, like he said, that we did no longer want the police officers there at all. So under Mayor de Blasio, he finally, relented and did that. However, his non-police response program, Be Heard, did not have a peer on the team. So, and you know what else? We'll go into Be Heard, but they didn't have anyone on the team. They only worked 16 hours a day, 7 days a week. The other times when the Be Heard was not up and running, the police officers handled the calls. And there are a lot of situations going on with Be Heard, but people with untreated mental illnesses were 16 times more likely to be killed by police encounter. So so far we haven't had anyone die other than Wayne Rosario under the Be Heard program or anything. And the problem with Be Heard is that you cannot call and request them. It's up to the 911 operator to decide if you are, I would say, worthy of a Be Heard team. So yeah, we can go to the next slide.
So as Evelyn pointed out, we had a new system put in place called the Be Heard program, the Behavioral Health Emergency Outreach on the Streets response that was supposed to filter through a new 988 system of care that was introduced a couple of years ago. Be Heard was sort of based on what we were seeing around the country. Mm-hmm. And there's a group called Cahoots in Eugene, Oregon, Crisis Assistance Help Out on the Streets, that has actually been using a peer-led model for over 40 years. We also saw what was known as Daniel's Law, which was a piece of legislation developed after the unfortunate crisis death of Daniel Prude in Rochester, New York. And many of the places in Denver, New Haven, and Connecticut were offering different types of response. We can go to the next. Go ahead, Jim.
The place in Denver, They did a presentation to us, and they're like really working hard of making a great model. And they came up with crisis response trainings that are really effective and seem to work. And then there's another place in Toronto. So, you know,
Steam Center.
yep, everyone believes that this is the way to go, and they're trying to come up with models. And, we just want one here in New York City that works.
Thanks, Jim. We can head to the next slide.
Okay,
Jim,
so
would you like to take that on?
sure. So for what's going on now here in New York City for crisis response, so Be Heard, is what New York's trying to do. They have EMTs and paramedics and a licensed social worker that go out. As Evelyn said before, they operate 7 days a week, but only 16 hours a day, and only for the 5 boroughs. And it doesn't even include the entire borough that they're in. So it's a collaborative program that's run by New York City Mayor's Office, the FDNY, NYPD, and the Department of Health, which includes NYC Health Plus hospitals. And we are really trying to get away from, especially the NYPD being involved, like in any way, shape, or form.
And they all work together. So if the NYPD directs they're the first people that usually show up. So the FDNY and the paramedics, they will do exactly what the NYPD will tell them, which is why we don't want to have any city agencies involved in helping people in crisis.
So we can go to the next slide.
So this slide shows some of the data that we've been able to get. I would like to point out the data from the Be Heard teams is very challenging to obtain. It seems to be be kept under wraps. And so that's a struggle for us and for other agencies and New Yorkers. So every 3 minutes, a New Yorker reaches out to 911 for mental health assistance. And this data is from, July 1st, 2023 through June 30th, 2024. And there were about 51,000 total mental health calls in the pilot area for Be Heard. 30,000 of those calls were not eligible. 20,000 of them were eligible to have a Be Heard team sent out to them. In about 15,000 of those calls, the Be Heard team responded, and only about 7,500 of those did they actually make contact with the person in crisis. And then only 3,691 people out of 51,000 eligible calls received some sort of mental health assessment.
With the Be Heard teams, they have nowhere to take the individual other than to the hospital. We have crisis respites, but I don't think they're allowed. I believe that you have to be referred to by a social worker or some other clinician to get into the crisis respite. We don't have any crisis stabilization centers, or maybe one or two of them, which is definitely not enough for the volume of people that need assistance. Yeah. So we will, and with the statistics with the city, they changed the numbers like you're changing clothing. 1 minute it's 51,000, the next minute is 20,000. So their data is definitely not reliable. Next slide. Thank you.
So this slide talks about what happened at the September oversight hearing. So Eva Wong from OCMH testified that Be Heard teams operated in only 31 of the city's 77 precincts. And like we stated before, it's only 16 hours a day with 9 teams during the day and another 9 in the afternoon. She later said that the city will switch from using police precincts as graphic boundaries to maybe more flexible ones that are more aligned with how the EMS units are dispatched. Then on the training of 911 and 988 dispatchers, Chief Obi from the NYPD said dispatchers have a full day training on mental health.
It's not enough, but yeah.
It's not nearly enough. They play a vital role. Like they were the first person that they talked to, and they are only receiving limited training when they have to figure out, should the police go, should it be a Be Heard team, and they have, questions that they have to ask. And we would definitely like the calls to come through 988 and not go through 911. So then NYPD always connects the person calling with EMS. Then those dispatchers go through 10 full weeks of training to receive assignments. And when new procedures come out, like Be Heard, they can categorize them appropriately. And 988 dispatchers are trained in what services are available in the city. Lots of times, the benefits of calling 988 is that a lot of the calls can be handled just by talking to someone from 988, and they can help someone through a crisis. So we all highly recommend that someone call 988 when they're in a mental health crisis, as opposed to calling 911. And then an administrative representative explained that dispatchers follow a triage algorithm. They assess whether there is violence, weapons, or suicidal behavior involved. And if none of these conditions are present, the call is typically routed to Be Heard, which is a vague way of talking about it. But in addition, one of our issues is that if there's suicidal behavior involved, that Be Heard won't go out. I'd have to say that on the mobile crisis team that I was on, about 70% of the calls were involved suicidal behaviors and desires. And I can guarantee that a peer specialist is much, much better equipped to handle someone who's having suicidal ideations than a police officer is. And that was really one of the more effective things that we did as a team.
So we can go to the next slide. So as you've heard, the Be Heard program became the default crisis response system that was supposed to be a non-police driven system. But as you've heard again, a lot of issues with triage, dispatch, timing of these calls, the staffing of this program to really respond to the calls that are needed, and the hours that we're operating on. What happened if your crisis happened to be after hours on the weekends? Forget it. But the biggest piece that we are continuing to talk about is the fact that there is no space right now on the Be Heard model for peers.
Yes.
And that is the focus of what Correct Crisis Intervention today in New York City has been for some time now, that we need to bring peers to this equation to be fitting with what we're seeing in other crisis response models around the city and around the state and around the country. So a non-police, non-coercive response needs to be for every crisis call. 24 hours, 7-day-a-week operation. Peers need to be on these teams. They need to be providing oversight. They need to be involved in the development of training and policy procedures. We also need to engage the communities that we're serving. As you heard, a lot of Be Heard teams were focused solely on police precincts. There wasn't a lot of thought given to how geographically the needs of those communities might be diverse and different. Our model calls for true transparency, in-depth evaluation, the opportunity for partnership, and good quality follow-up care. It's one thing to have somebody helped in response to a crisis, but what happens after that? Where do they end up? Do they get the help that they need? Do they make the connections that they need? None of these things are really part of the Be Heard model currently. So we'll go to the next slide. Jim or Evelyn, would you like to take this?
There are many ways that you can get involved. You can attend our March 24th Peers Not Police rally on City Hall steps. It will be at 9 o'clock a.m. Or you can provide testimony, written or oral, for the mental health preliminary budget hearings, which is also scheduled on that day at 10 o'clock. You just have to go in and register, or if you want to submit a written testimony, you can go online to the City Council's website. You can have your organization formally sign up to the CCIT-NYC Coalition, or you can arrange for a presentation to be at your office or your organization. You can spread the word and promote our press among your network. We CCIT also we also have a lawsuit going on, the Viagra lawsuit, and it's we are suing New York City because they have violated our ADA, American with Disabilities Act, rights, and other people have been injured because of this. So we're currently in courts right now in the federal court system. I'm not going to say anything about that, but yes, that's who we are currently. And they had did something similar in Minneapolis, and they were found to have violated a person going through a mental health crisis rights. So we are definitely on top of it. Yeah. So thank you.
Thanks, Evelyn. So our advocacy right now is really around the budget, and that March 24th date is a key budget hearing with the mental health committees and other important committees at City Council. So we will be rallying and then also spending the whole day providing testimony. We will send out these slides to everyone with our contact information. And a question came up in the chat, how can we arrange for CCIT to make a presentation to your community? Definitely get in touch with us through the slides and our contacts, and we will arrange to come out to you or do a virtual presentation. A big focus on our agenda right now is really broadening our community outreach and finding ways to add folks to our committees. We have a number of working committees, a part of our steering committee, and we'd be glad to bring that presentation to you or customize it accordingly. Again, our message right now is peers, not police. Yes. And we will also send out a link to the New York One video that we were recently on. We have a website, CCIT-NYC.org, which has a lot of our testimony, a lot of our presentations, our model, and our submissions. There you go in the chat for folks to follow along. We would love to have you sign up to our committee. Our focus, as I mentioned earlier, is really to bring folks with lived experience into this community. We're a robust group, but we're really seeking additional membership.
And I also like to say that I originally got involved in CCIT just by kind of randomly going to a Peers Not Police rally on the City Hall steps, and it goes for about from 9 to 10:30. And if you've never been to one, it's an interesting experience, and that's how I got involved, and I liked it a lot. It's a really positive thing to do.
Yeah, it makes a difference.
So I think that may be it on the slides, Harmony. I don't know how you would like to handle the Q&A.
Yeah, thank you to you three so much for this presentation. I see a few questions in the Q&A that I can read aloud to you, and you could take turns addressing them. I also have a few updates and questions from myself. Yeah, we're just really excited to see all the work that you are doing to promote the Peers Not Police campaign. Look forward to the rally and opportunities to submit testimony in a few weeks. You mentioned the, utter importance of, bringing in peers to the committees, and not only like peers in the model and peers in the committee, but peers in leadership. Can, any of you talk about, the value of having peers as part of the committee and leading the way in which policies and programs are designed and how they helped with this current model?
Sure. So peers, I work as a peer specialist, and I went to the Howie the Harp training program at Community Access, which is an excellent program where you learn all about being peers over 7 months and then do an internship. So as a peer specialist, I bring a much different perspective on, behavioral health treatment. I'm like pretty much solely focused on the recovery model as opposed to the medical model. And what I find one of the more important things in my work is to be an advocate, not only, for the peers that I work with, but that in my clinical meetings, I bring a different perspective and try to explain what it might be to have a mental illness. I too have a bipolar disorder and PTSD, and it and sometimes it's really helpful for, say, social workers or harm reduction specialists to see like what I might say about how someone is treated in the hospital, like what that might actually do to them, especially based on the people that our team serves, the incredible level of trauma that some of them have been through. And in that way, I find that being a peer specialist, really helps people understand more about what's going on with other people.
Also, peer specialists, they know what it's like to go through a crisis. They know what it takes to, calm someone down because they've been through it also. Yeah. So they know how to take care of things. They're very instrumental in, nothing about us without us is what we always say. So if you want to have a program, at least include the peers because they already know what to do and what can happen.
Just to add to that, we are looking to expand our steering committee, and really looking for that steering committee to be 2/3, if not all, people with lived experience. So finding ways for you to get involved if it's in a legislative event. We can also introduce you to our monthly meetings. We also have a membership meeting that we typically do 3 to 4 times a year that you can be invited to, as well as anyone else from your community.
And we also have general meetings every quarter, so we can let you know what's going on in the crisis response arena. We usually send out invitations a couple of weeks before the actual event. So we'll give you the information that you need, that you can sign up for that also.
Did that answer your question, Harmony?
Yeah.
Yeah. Oh,
Okay.
definitely. And yeah, I'll definitely make sure we send out the sort of sign up, it seems like, to receive emails about general meetings. So thank you for that. I'm glad you also mentioned how individuals can get involved, by participating in meetings, by contributing, in ways listed on our screen. Are there additional ways organizations can be involved in addition to, signing the coalition letter?
I believe they can submit written testimony or testify at the hearings. That's very helpful also, and also spread the word. But if you really want to make a big difference, I would say writing testimonies to city council departments, and also writing written testimony or going into city council and give your oral testimony. I do believe they have some on Zoom that you can have a choice, but that's something we'd have to find out more about. But you are able to testify.
And we'll be putting out a set of talking points specifically to that March 24th hearing to help guide your process. You know, a lot of folks feel intimidated about testimony at City Hall. We like to say that, you know, telling your story or a piece of your story is so important. And, you know, the folks on this call, if you work with folks recovering from mental health issues, you yourself, those types of inputs and are so valuable to this process. So we're not asking you to read verbatim what our talking points are. Think about what we're saying and how you may want to say it, whether that's written, oral, or submitted online. It's well worth doing. We also have other email campaigns that we will be sending out to this group and others for your input.
Also, Harmony, we you know, we like talking to other organizations about what they're interested in doing and how it may work with what we're doing and see what we can figure out.
This is all really great. Yeah, thank you so much. I am sharing a general feedback survey that we use for all of our events. If you have feedback from this event or have ideas for future events, we really appreciate it. I'll get to questions now that are in the Q&A. Please feel free to keep them coming. But one person notes, when police officers live outside of the community, they sometimes lack understanding of how to serve constituents in that community. Are police officers more willing to gain the training needed to have better responses when there is a mental health crisis? Or is there some bureaucracy that prevents this from happening?
I would say in an ideal situation, someone, go ahead. You can go ahead. Anyone? Okay. I think that they don't necessarily want to harm an individual. However, you know, unless you have the proper training, being in a situation, in a crisis, it can be very scary, which is why we don't want them to be there in the first place. You know, it's better to have a peer there.
That's huge. What Evelyn is speaking to. You know, we've had conversations with police and leadership at NYPD, and the first thing we hear is that they don't want to be the social worker, the first responder to these types of situations.
Mm-hmm.
That so often incidents, crises can be de-escalated and funneled appropriately to the right resources. Many of us in this industry are providing alternate settings with the right counseling and support to help de-escalate crises and connect people to care. And really, that's what the police are looking for. If they can have a suitable community to bring people to, rather than the emergency room, rather than the police precinct, it's a win-win for them. The training still exists. It's still going on. I don't know how robust it is as before, but officers still have that 3-day mental health crisis training at the academy. How often it's renewed and updated is a key question too. I think it may be a one-time only deal.
I wanted to say, Jim, that I was invited to a police forum where they were asking us, you know, about peer specialists and also crisis response. And I told them my story, and they, you know, they appreciated it, and they're really trying to, I believe, hopefully, stop allowing people from being killed during a mental health crisis. So yeah. So I would say they're trying. However, we still don't want them there. They do need training though, because the NYPD are usually the first people to show up, and they want to take control over the situation. So there's still a definite need for them to be trained.
Definitely. I think this also feeds into someone else's question I see. This person says, "It has been my experience that it doesn't matter what you say when you take the call. Police still comes and sometimes treat the person that is going through crisis like a criminal. I've had several clients removed in handcuffs, even when they were cooperating, and social worker and case managers explained that they were not violent and just needed to be taken to the hospital. Is this something your program might help with? And do you have any advice as to what to say when people make phone calls?"
I will say definitely call 988, not 911. 911 operators, I mean, I usually say this. If they hear someone screaming and yelling in the background, they're going to think that someone is being injured or what have you, and then they'll dispatch the police because they want to make sure that they're doing what they think is the right thing. So yeah, I would call 988. That was put into place for occasions just like that with crisis response. So rather than call 911, call 988.
So thanks so much for your question, Anna. So I'm going to guess that these are situations where the person on scene from the agency has decided that the person is no longer is a danger to themselves or danger to another, and actually what you're looking to have happen is for them to actually go to the hospital and be evaluated there. Because there are times when this does happen, like based on even people who know the client in this situation. And there are times, like technically what is supposed to happen is an ambulance and a police are supposed to show up. And sometimes it's just an ambulance, and other times the police come, and sometimes it's police that don't have any training, and just the way they see it is to keep themselves safe. Or I'm not sure.
Mm-hmm.
They just throw somebody in handcuffs and want to throw them in the ambulance or in their car. Um, it's we've talked about it, and one thing that people might try to say is that someone's experiencing psychiatric symptoms. But sometimes it doesn't matter if you're talking to a dispatcher and they only want to hear is it an emotionally disturbed person?
EDP.
And it is really confusing when, I mean, I haven't gone through this, but it sounds confusing when you're there and you're like, I know the person, they're safe, they're not going to hurt anybody, but the police still do what they want to do. And this is something that, like, I would like, to figure out how we can make this better.
Thank you. I put in two events coming up led by the consortium. One training is on Access HRA benefits on March 20th. And the second one is called Flipping the Script, and it's a teach-in on homelessness and medical respite, where we have a panel with people with lived experience of homelessness who've participated in medical respite, teaching healthcare providers about what that care can help and can look like. We have a few more minutes for questions. At the same time, I'm going to launch an anonymous evaluation poll. Someone asks, there are several people who would like to get involved in this line of work. Those who are formerly incarcerated. How do they get involved? Do they need a support or formal letter to get involved, or how can they get in touch?
Yeah, we welcome your input. Definitely reach out to us through the CCIT-NYC.org webpage, or you can respond to us on this meeting invite today. Jim, Evelyn, myself would be happy to talk to you further and welcome you to that community.
This question might be for Jim B. Can you clarify what types of referrals would this team accept, and how is it different from mobile crisis?
So the to me, the type of referrals it would accept would be people calling in through 988 who have pretty much any kind of mental health crisis, including suicidal ideation or desires. Certainly when 988 does have to, they would have to determine if it's safe for a team to go out, right? I mean, in most cases it is, but if there's someone has a gun and they're threatening someone, that wouldn't be a case where a mobile crisis team would go out. In terms of how it's different from mobile crisis teams here in the city, so this team would be citywide. Mobile crisis teams are more regional, and they're run by specific agencies, and they focus more on resources. And because someone I know works on one of the teams, and not as much de-escalation, she says. In addition, it's unclear to me how the referrals are made to mobile crisis teams. And that would be one of the major differences, and that we would also respond quicker. These teams would respond much quicker than mobile crisis teams.
Thank you. Someone asks, can I call 988 for my client at a safe haven? Sometimes the crisis does not need police. I'm not sure if, are any of you able to answer that?
So I could say that it depends on, my training. I have a lot of experience with people in crises and helping them through it. And I feel, due to that experience and training and my approach, I feel comfortable like dealing with that. But I don't know. It depends on the different provider and, their experiences. But certainly, you could call 988 and see if the person in crisis, if talking to the person on 988 could help. Just because they are technically pretty good at de-escalating someone, and just talking through the crisis can really, really help. So I hope that answers your question.
I think so. I have one more question from the audience. She said she has a client whose family member weaponizes her mental health status and uses calling the police to control her. She states that police officers say they have no choice but to arrest her and take her to the hospital. She's afraid of her family doing this to her again. What resources could she share with her around this situation?
Oh. Hmm. I can understand what she's talking about. I experienced that once, so I can't imagine how they feel having to go through that over and over again. Um, I don't I don't want to give her the wrong information, but yeah. I mean, she would have to get support from um people that know her doctor, or even, talk to the officers and tell them, look, I'm not doing anything wrong, or, what have you. And, to be honest with you, I've heard some police officers complain about that, these family members keep calling 911 on individuals who don't need to be taken out of their homes. And lately they've been taking a lot of people out of their homes, a lot more than normal. So, yeah, something has to be done about that. I'm sorry you have to go through that. But it's, yeah.
Well, thank you, Evelyn. I think, this webinar has been really helpful for our audience. I think it's a really important topic to speak with or to speak about. And yeah, thank you so much for leading today's session. And I hope people came out of it with a lot of next steps and a lot of action. Um,
So Harmony, it looks like there's a couple of questions in the chat itself.
Oh, where? Let's see.
Um, Leslie asked, how can we arrange CCIT-NYC to present to our community? You can send one of us an email and we can figure it out from there. Are you all volunteers? Yes, we're all volunteers.
But we get a stipend. We get a stipend. The peers get a stipend.
Wow, awesome. I didn't know that. Now I'm excited to get my
You didn't know. Yeah, peers get a stipend for attending meetings, doing presentations, and preparing for presentations. Yes, peers do get some kind of stipend.
Sorry, Jim,
Only
you're
peers,
a
though.
volunteer.
Only peers. No one else. I thought you knew, Jim.
Now I do.
Okay, now you do.
So I
Um,
think that was all of them.
Thank you for looking through the chat. But oh my gosh, thank you so much. Um, I hope you all have a great rest of your day, and we'll follow up with the slides, the recording, and some of the resources, such as signing on, how to sign on to a committee, how to sign on for general meetings, and looking forward to like resources related to submitting testimony.
Thanks, Harmony. Thank you,
Thank you.
everyone.
All
Pierce
right,
Thank
not
thank you,
you.
police,
everyone.
guys. See you on the 24th.
Yeah.
Thanks
Have a
so
good
much, everyone.
All right, thank you.
2025 is a year for peers.
Yes.
Yeah.